Welcome to this explainer. Today, we're diving straight into the clinical workflow for evaluating uterine fibroids using ultrasound. If you're gearing up for rotations or studying for your board exams, getting a solid handle on these sonographic images is an absolute must. So let's jump right in and look at exactly what you need to hunt for when reviewing a patient's scans.
Here's our roadmap for today. We're going to hit normal anatomy as a baseline, check out classic fibroid ultrasound findings, look at calcification and degenerative changes, categorize their location and vascularity, do some clinical correlation and measurement, and wrap it all up with a sonographic evaluation checklist.
All right, part one, normal anatomy as a baseline, establishing the standard.
So before we start spotting pathology, we really need to know what we're actually hunting for, right? Uterine fibroids, or leiomyomas, are the most common benign tumors of the uterus. They're literally so common, you're going to see them all the time in practice. And guess what? Ultrasound is absolutely your first-line imaging tool here. It's accessible, non-invasive, and highly effective. Take a look at the striking contrast on this scan. On a normal uterus, you get this beautifully homogeneous myometrium with a distinct, bright echogenic line right down the center. That's your endometrial stripe. But throw a fibroid into the mix, and bam! That smooth contour is totally distorted by a dark, hypoechoic mass. Recognizing that smooth, normal baseline is the only way you'll reliably spot the abnormal.
Moving right along to part two, classic fibroid ultrasound findings, identifying the pathology.
Okay, so you spot a suspected fibroid. What exactly are you looking for? The classic presentation is a well-defined, solid, hypoechoic mass arising right from the myometrium. And just as a quick reminder, hypoechoic just means it looks darker on the screen than the healthy surrounding tissue. It's kind of like a dense shadow sitting right there in the muscle. That distinct, smooth-margin dark mass, that is your textbook leiomyoma. But here's the thing. The mass itself isn't your only clue. You gotta look at what's happening right behind it. Because the fibrous tissue of the tumor is so incredibly dense, we frequently see posterior acoustic shadowing. It basically blocks the sound waves like a boulder blocking a stream, creating this distinct dark shadow that drops straight down behind the mass. Solid hypoechoic mass plus a shadow? Yeah, your suspicion should be very high.
Next up, Section 3, calcification and degenerative changes, spotting the variations.
Now, fibroids aren't just static, they change over time. As they age, they can become calcified. This creates a dramatic visual shift on your screen. They become highly echogenic, meaning they show up as extremely bright, stark white areas. And since calcium is incredibly dense, you'll see very intense acoustic shadowing right behind those bright spots. On the flip side, what happens if the fibroid outgrows its blood supply? Well, the tissue actually breaks down. This is a degenerating fibroid. It loses that solid, uniform look entirely. Instead, it becomes heterogeneous, taking on a mixed, almost sponge-like or Swiss cheese look, riddled with dark, fluid-filled cystic spaces caused by the dying tissue. It's a totally different picture. All right, Section 4, categorizing location and vascularity, putting our findings into buckets. Once you've actually identified the fibroid, your next step in the clinical workflow is categorizing it strictly by its location. Is it intramural, meaning it's buried completely inside the muscular wall? Is it submucosal, pushing inward toward the uterine cavity? Subserosal, bulging outward, or maybe pedunculated, just hanging on by a stalk? Figuring out the location is just as crucial as making the diagnosis itself. Now, to differentiate a fibroid from other possible uterine masses, color Doppler is absolutely your best friend. When you switch that on, look for peripheral vascularity. You're often going to see this prominent ring of blood flow hugging the outside of the fibroid. That peripheral pattern is a classic sonographic signature confirming that it's behaving exactly like a leiomyoma. That brings us to Section 5, clinical correlation and measurement, connecting the scan to the patient. So, what does all this actually mean for the patient sitting in front of you? Well, these masses can cause some life-altering symptoms: heavy menstrual bleeding, severe pelvic pain, infertility, and pressure on surrounding organs. But fascinatingly, many fibroids remain completely asymptomatic. You'll often discover them as purely incidental findings when you're scanning for something else entirely. It's also super important to realize that you aren't always just looking for one isolated leiomyoma. Patients very often present with multiple leiomyomas. When this happens, it can significantly enlarge the uterus and totally warp that nice, smooth, normal contour we talked about at the beginning. The sonographic landscape can literally turn into a complicated map of overlapping masses.
Because it can get so complicated, your ultrasound reporting workflow has to be highly structured. Step 1, identify the mass using those classic visual hallmarks. Step 2, precisely measure it in all 3 dimensions, length, width, and height. And step 3, explicitly document its exact location. Every single fibroid you find requires this level of structured documentation.
Finally, Section 6, the sonographic evaluation checklist, your final review.
Let's bring it all together into an ultimate diagnostic checklist, perfect for board exams or hitting the floor. When evaluating, look for that well-defined hypoechoic mass. Note any posterior acoustic shadowing. Check for the bright white echogenicity of calcification or the dark cystic spaces if it's degenerating. Flip on the color Doppler for that peripheral vascularity. And lastly, always measure in 3D and document the location. Tick those boxes and you've got it.
So we've nailed down the steps for visualizing these super common tumors, but I want to leave you with a crucial thought to chew on as you continue your studies. Now that you can flawlessly identify a fibroid on an ultrasound, how exactly will its specific location, say intramural versus submucosal, dictate your patient's future fertility? It's a massive question and a perfect example of how anatomy directly drives clinical outcomes. Thanks for joining me on this explainer. See you next time.